Well, welcome everybody to Optometric Education Consultants National Webinar Series Tuesday night edition. Tonight's topic is Pharmaceutical Update 2025, a synchronous virtual course with my partner, Dr. Greg Caldwell. He is a graduate of the Pennsylvania College of Optometry, where he also did a residency. He is a contributor to the optometric literature and the optometric knowledge base, has participated in many clinical studies. He is an ocular disease consultant in Pennsylvania. He has lectured nationally and internationally on all pharmaceutical topics, glaucoma, pharmaceuticals, retinal disease, OCT technology, and he is a member of the Optometric Glaucoma Society. And in 2023 was one of the top 200 optometrists by Newsweek magazine. So with that, Greg, please take it away and update everybody on what's new in pharmaceuticals in 2025.
Perfect. Thanks, Joe. And thanks for that nice introduction. And thanks for almost having the cover. So appreciate that. Here are my disclosures. I have Alcon, B&L, Dompe, Lens. I'll just cover those because I might be speaking on those companies. I've lectured for them, received honorariums, advisory boards for Dompe, Tarsus, and Envision, received honorariums. I don't have any direct financial proprietary interest in any of the companies I just mentioned. I am a non-salaried affiliation with Pharmanex and New Skin. I don't believe I'll be covering anything there tonight. Healthcare Registries, chairman of Advisory Council for Diabetes and Macular Degeneration. That is an outcome-based registry. I think everyone's figured out Joe and I are the owners of Optometric Education Consultants. With that said, the content of this activity was independently prepared by me. No one's telling me, or when Joe makes his comments tonight, telling us what to say. I will be mentioning products, and then when I do, it's without commercial bias or claiming superiority out there. But more importantly, everything has been mitigated through the CE broker and COPE process. Here is my practice. I practice in Western Central Pennsylvania. I've kind of summed this all up that I try to be an optometric translator, take all this science out here and translate it how we can use it better in our clinical practice. All right, so here's the pharmaceutical matrix that I like to cover. And with that being said, there's the commercial sales, there's the medical science liaisons. We can see clinical research, marketing, and market access. I really want to cover the sales side of things here. Those are the reps that come into your office. What I always like to point out is they have to be on label. They can do the educational lunches, they can do the discount cards, but I always tease if you want to get rid of a sales rep, just talk about how you're using it off label because really they have to speak on label. They have to be fair and balanced when they come in. They have to tell you, what the product is used for, how it got through the studies, what it works for, why it's good, but then balanced out with maybe it stings and burns and blurs the vision. So it's got to be a on-label type. So like tonight, we're going to talk about MIEBO, and MIEBO is used 4 times a day. And I think some of us are using it 2 or 3 times a day, but they have to promote it as 4 times because that's the way it was done in the study. Now, the medical science liaisons, those could be pharmacists, PhDs, MDs, DOs, it could be a wide variety of degrees. They really, are about education. They can speak off label. They're the ones that can take a deep dive into the science or maybe some of the phase 4 studies that are out there. A lot of the times whenever I'm putting these together, that's who I'm hanging out with. Not to say there's anything wrong with the salespeople, but the salespeople really can't get into the deep dive. So what will happen in your office is that if you start talking off label or you have a question about off label, they will connect you to the science team, the science side, and that's the medical science liaison. We just had our Nashville meeting. We had 4 medical science liaisons at our meeting. They kind of float around. They really don't hang out much at the sales table, but they're there just in case, the audience has questions. So, the medical science liaisons are probably the most underutilized asset in a pharmaceutical company. So if you ever have any questions, please reach out to them. All right. So reason for eye drop non-adherence, really you can see here there's a whole bunch side effects, RX cost, bottle runs out, so on and so forth. Reason why I want to point out, you're going to see like difference in bottle sizes, changes in the drop, so on and so forth as we go through, and it's really trying to address the non-adherence. What I want to point out, doesn't matter how good you are. I graduated in 1995, been putting lots of drops in over the years. And most drops, whether it's proparacaine, whether it's fluoresce, phenylephrine, tropicamide, the size of that drop is 30 to 60 microliters. And what I want to point out is the eye can really only hold about 10 microliters. So that's why anytime you put a drop in the eye, no matter how skilled you are, you're going to get a little excess running down. The patient's always going to have to dab their eye. And the reason why I'm pointing that out is you're going to see when I go through the slides tonight that you're seeing that this drop size is shrinking. Vivi is, 10 or 11 microliters. We have MyBo the same way that's out there. So you're seeing that now when these new drops come out, they're actually just accommodating and trying to get away from the waste whenever the eye can really only hold 10, and most drops are 30 to 60 microliters. And that's why you've seen this device, this nano dropper. I know the owner pretty well and the developers of them pretty well, and I always pick on them. They call it a nano dropper. I like the name because it's trying to tell you that it's getting to drop down to be nano sized, I guess, in a sense, or smaller. But really, the key is why I pick on them is that we're talking microliters of drops, 30 to 60, and you put that, screw cap on, and it drops it down to that 10 microliters, helping to save. I actually put them on my, phenylephrine and my tropicamide in my office. Not that I'm trying to stretch the bottle out. It's just sick and tired of them having drops run down their face. So this has been a nice little device, and especially for patients that have trouble getting their drops in or maybe always running out. These are pretty affordable little devices, and there's been plenty of studies out that it doesn't affect the efficacy when you're you know supposed to be a 30 or 40 microliter drop and you're shrinking it down. They have shown, and it fits a variety of the bottles that are out there. And again, here's kind of showing timolol. Even though you're shrinking it down, the IOP still works, but maybe even a little bit better with less of the heart rate side effects with a little bit less drop. So less side effects maybe, but the drop is working just as fine regarding efficacy. Always like pointing out, if you have a glaucoma practice, you have an ocular surface disease practice, basically from the BAK that has been beating up on the drops. I've been following glaucoma patients now, 20, 25 years since we've been able to do these drops for our patients. And I've seen the negative side effects that these drops can do while pounding their ocular surface. And we always like to have evidence-based medicine. So, here's a picture of one, and you can see, let's look at the severe. And basically, the first column is 1 drop versus 2 drops versus 3 drops. And you can see the red get larger as we keep adding drops. And you can see the green get smaller as we keep adding drops here. So, I don't think it's a huge study, but I think it's more common sense. The more BAK, great preservative, but also great at beating up the ocular surface, the conjunctiva, the cornea epithelium, disrupting the tears, making the tears, osmolarity readings go high. And then now on top of it, you're disrupting the lid microbiome. You're putting this preservative on there. We have normal flora that live on our eyelids, and it disrupts it. Just like in functional medicine, we talk about the gut microbiome getting disrupted. We have a lid microbiome, and that gets disrupted from these drops and messes up the meibomian gland, messes up the tears, destroys the epithelium. And so all in all, if you have a glaucoma practice, you have an ocular surface disease. Now, in the United States, it's a little bit different than Europe. In Europe, they like to use the preservative free. We have a tough time getting those covered in the United States. And you can see there's a huge list of all the glaucoma drops. and the different percentages of BAK. Not throwing BAK under the bus because it's a fantastic preservative in a multi-dose type of setting, but it's also a fantastic way of beating up the ocular surface. We do have eye drops over here containing alternatives like alpha-GAN P and Zelpros and Travatan Z with Sofzia. And we're starting to get a little bit longer of a list here with, IUZA coming out most recently with Predforte preservative-free, COSOP preservative-free, which I'm finding to be pretty well covered by the insurances. I've been playing around with that in 2025 and pleasantly surprised by how well that is covered by insurance companies. And again, we like to have studies, we like to have evidence-based medicine. This was the relief study, just switching people from latanoprost to preservative-free latanoprost. And you can see, even though it's a prostaglandin analog, just by removing that preservative, the conjunctiva hyperemia, blepharitis symptoms, and tear breakup time all improved just by one change, changing that preservative that's out there. So I'm trying to point out all these different highlights so that as we go through, you'll see why some of the bottle sizes and drop size have changed. So Joe, here is the first polling question, if you could launch it.
Of
Um,
course.
when I think of a pharmaceutical, I consider mechanism of action and mechanism of delivery.
All right,
When I
poll
think,
is opened.
yep, perfect. When I think about a pharmaceutical, I consider mechanism of action and mechanism of delivery. Yes, no, or perhaps after this lecture, I will.
Interesting, Greg, as you're going through the non-preservatives, you jogged my memory on something. So I took a moment to look up something on GoodRx. It seems like Tim Optic and Ocudose, as long as it's been out there, it just does not seem to ever get inexpensive. With a coupon, the best price I can find for that is $127.
Wow, that's kind of crazy.
Yep. I mean, I remember when we had to use or we wanted to use it early, years ago. It was like about $300. You'd think it would come down. But
Well, I guess
Tim
it did,
Optic,
but not what we would say
yeah,
clinically significant.
yeah. Tim Optic and Octodose, still unaffordable after all these years. All right, I'm going to close the poll and display. 59% said yes, they consider mechanism, action, and delivery. 7% say no, and 35% say perhaps after this lecture I will. And I think, Greg, that will be your target audience, that 35%
Yep,
change
perfect.
their mind.
Perfect. Yep. So let me just help out here. So when I'm talking to an MSL or a new drug comes out or um, um, or talking to a sales rep, I try to figure out what are they trying to do here. So let me just talk about mechanism delivery. There's been so many lotipredisols come out over the last few years. And the lotepredinol, the carbon 20 change on it, nothing's really changed in that mechanism of action. But we have 1%, we have 0.5%, we have 0.38%. And like Lotomax SM is like what I'm showing you here on this picture here. It's a very large molecule, and they went actually to a submicron, and they lowered the percentage down to 0.38%. Now, I lecture with Dr. Offerdahl from time to time, and I hang out with pharmacists from time to time. And when I ask them, how about 1% going to 0.38%? Is that a big deal? They're like, oh my gosh, anytime you can use less medication on the body, the immune system reactions, the side effect, absolutely that's a big deal as long as you get the same efficacy. And I said, what about simple as going from QID down to TID? And they're like, Greg, it's the same thing. When you use less medication and get the same effect, that's always a benefit. So that's usually what's happening when you start seeing these a mechanism of delivery changes that are out there. So 1% down to zero, down to a 0.5%, 1% down to 0.38%, TID dosing versus QID dosing. And then we'll talk about the cyclosporins. There's, in a sense, three different cyclosporins, Restasis, Cequa, and Vivi out there. And you'll see that they changed the percentage, which is good, in my opinion, but they've also changed how they deliver a nanomicellar or a perfluoral alkane to deliver it. And so I always use the analogy is like, okay, I like vodka from time to time, but if you put it in tomato juice, I'm not going to drink it. I'm really not a big fan of tomato juice. But if you put it in a ginger beer, there's probably a good chance that I might do one, or put it in a tonic. I'll probably do a vodka tonic with it. But if you put it in tomato juice, so it's the mechanism of delivery, the mechanism of action would be the vodka and all those that are out there. Now, mechanism of action, we've had some changes. It was pretty boring for a while, but now, back in 2017 or 18, that was the first really mechanism of action change of a glaucoma med all the way back to Xalatan. And then recently we had Mibo and XDemV come out, and Triptyr and aceclidine this year with Viz. These are now some new mechanism of actions. And actually Viz has a little bit of a mechanism of delivery with their proprietary way of their vehicle. And maybe we'll get to the chance of talking about that. So receptors are important. Remember, all of these medications plug into receptors. This is just from my opioid, reminding that the opioids plug into mu, kappa, delta. When I started lecturing in pharmacology years ago, the pharmacist said you have to remember, Greg, two things: receptors and the immune system. And here you can see it's just, again, just how opioids plug into mu, kappa, delta, how they're found all throughout the body, and that's why you get the different side effects. I think we all know if you take an opioid, it plugs into the breathing center, and maybe a side effect would be decreased cough. That could be good, but too much of it can cause a respiratory shutdown. Oops, that's too much. That's not good. Or constipation. So remember, they plug into receptors, maybe to help us with a certain outcome, but also maybe a certain side effect. And then the immune system here. I've needed a crash course. I took some extra classes in the immune system. Really understanding the immune system has helped out so many ways. But this guy is Ninja Nerd. He's found on YouTube. He helps the medical students with their exams and help them to pass the exams. I love listening to him. He literally just starts with what's here in red and just starts drawing away. And he knows where all the interleukin 2s and 6s, and talks about the macrophages and so on and so forth. So if you want to watch, I think it's an 8-part series. I would encourage you to listen to it. Here's the innate, here's the adaptive. Here he's talking about the macrophage now presents the antigen, and then it starts the whole T cell, B cell, and all these different interleukin 5s and 4s, and then it eventually makes the plasma cell and then the antibody. So this is our adaptive immune system, which we learned so well of and got so reminded during the COVID years. But this is also what can go awry and cause an autoimmune disease. These T cells start to differentiate and create antibodies that then attack ourselves. And then right here, if you look in this little drawing, he talked about the complement system, and I have it kind of blown up right here, where he went, okay, the alternative starts with whatever this is, C10 and then C8 and what all these different are. It makes that membrane attack complex. You can see that there's the alternative classic and lectin. And remember, it's this membrane attack complex that will, and sometimes, in the bacteria, poke holes in it, causes it to swell, and that's how it kind of kills the bacteria. So the 3 parts here are innate, which immediately detects, and that's part of the macrophages. And then we have our adaptive and complement system. They're all kind of 3 distinct immune systems. And here I'm showing how Hashimoto's thyroiditis, this is kind of a slide from my thyroid lecture. You can see the CD4 T cell turns into a B cell and makes plasma cells over here. But it also in Hashimoto's can then create this destruction of the tissue, or it can create, an issue with the thyroid. These are the antibodies of thyroid eye disease. Over here in Graves' disease, you can see the CD4 cell, B cell, making this thyroid stimulating antibody attacking the receptors. So it's the immune system, it's receptors, it all kind of makes sense. And that's why, it's now easier to understand what happens with teprotumumab. This is Tepezza, which was originally by Horizon, and now with it's Amgen who now owns this asset, but it's a biologic and it's a insulin growth factor 1 receptor inhibitor monoclonal. You can tell it right here in the name, teprotumumab monoclonal antibody, and it's for thyroid eye disease, and it's actually an insulin growth factor 1 receptor antagonist for this. And so what we're showing here is that thyroid eye disease is an orbital disease. Remember, these antibodies that are receptor antibodies for the thyroid tissue, unfortunately, the muscle and the fat in the orbit look like this tissue. And here would be, let's just say, a fat cell in the orbit or a muscle cell. And remember, the insulin growth factor is important in muscle growth for those who lift weights and exercise. It helps to create, so these IGF-1s are found all throughout the body, but sometimes they get overexpressed. Sometimes with this beta arrestin down here, they are attached to another receptor, the thyroid stimulating antibody receptor, kind of makes it all one. And what happens is whenever it's being stimulated with an IGF-1 antagonist and the antibody from thyroid eye disease, now that's when you get the orbital inflammation, the muscle swelling, and the fat swelling. So what happens is teprotumumab comes in and attaches to one side of the receptor. And with this beta arrestin, it all becomes one, and it kind of shuts down that chronic inflammation. So kind of showing in the picture here, this orbital inflammation and how it starts to calm and helps to treat the thyroid eye disease. But I think we've learned over the years that with that comes some side effects. The most recently reported side effect that makes total sense to me, muscle cramping with a Tepezza. There's been some hearing loss reported, and people with irritable bowel syndrome, they really check after every infusion to see if the patients are having any of those issues. So years ago, I always said, if you're monkey with the immune system doesn't like to be monkeyed with. And for sure here with a monoclonal antibody, you're monkeying with the immune system. Even when you take an aspirin, your immune system will say, oh, what'd you put in me here? What are you doing? Let's check this out. Is this okay? So even in an immune system, so that's why if you watch the biologic commercials, they usually are monkeying with the immune system. That's why you'll hear on a 30-second commercial, maybe 5 to 6 seconds of what it's for, but maybe the other 25 seconds of how it could create a side effect. So kind of teeing it all up here for receptors and immune system. And we already touched on one here, thyroid eye disease with Tepezza. Now, with that being said, here's the Fonz, and the Fonz was on TV just a few years ago, tossing around how GA, everyone knew what GA was. I mean, I was even trying to figure out, even as an eye doctor, what he was trying to promote at first, but, geographic atrophy. And so, this is probably how Joe and I remember the Fonz, and now we're seeing him like this, promoting geographic atrophy awareness. So here we are here with some genetic testing, and I use this. This is visible genomics, and I don't do it on everyone, but I like to have it done because I like to see what's happening, whether it's low, high, moderate, what's happening with their arms, what's happening with their complement system. Let me just not make this a genetics lecture. But the arms is basically the combustion, how well the RPE, how well the photoreceptor is able to let's just say, kind of take in the glucose, burn the glucose, and kind of do it in an efficient manner. Whenever you have arms issues, as you can see, they could be low, medium, or high. If you had a high incidence, then the photoreceptor or the RPE might not be able to metabolize properly. The complement system and complement 3, those are your braking systems for your immune system. So remember, when you get your immune system turned on, you eventually want your body to say, okay, immune system, turn back off. And so those are your genes, like your complement factor H and your complement factor 3, that can be broken, right? So if there's a high risk, what that means is, okay, we can turn on, but we're having a tough time braking. And to kind of go off to a little offshoot there, that's why if you have someone that you give too much zinc in macular degeneration, 80 milligrams, plus it's in bread, plus it's in juice, that's why in some of the studies out there in certain genetic risk profiles, the zinc will actually slow down the braking system of the immune system when it's too high. So if you already have a certain genetic profile of the complement factor H and you're giving them a lot of zinc, it already has a braking problem. It's just like taking the brakes away or greasing the brakes or pouring water on the brakes. It has a tough time that's out there. So, but my point is in macular degeneration is there, we're talking about the complement system and the immune system, right? It's how it bridles itself. And again, it goes back to this part right here, not the innate, not the adaptive, the complement system. And we've seen some drugs come out in this arena that we're going to talk about here shortly. So I wanted to just kind of pull some evidence-based medicine here. This is a complement factor H in macular degeneration, bridging the genetic association and the pathobiology. And you can see here complement factor H and complement factor 3. Now, remember this, 3 and C5. So complement factors C3 and C5. Down here in the RPE, those are your genetic SNPs that are out there and can lead, that's bridging the genetic association and basically the pathobiology or the destruction of what's happening down here whenever you get in Brooks membrane, you start getting a buildup of the oil, you get a form of the drusen, and then you start having macular degeneration or geographic atrophy. So remember, genetics, immune, C3, C5. Here's a geographic atrophy patient that I had in my practice. This is over a course of about 4 years. And you can see this is back in maybe 20, maybe this is 6 years, maybe 2019, 2020. This might be 2023, 2024. So maybe that's around that 4 to 5 years time span. But you can see here, this is a fundus autofluorescent. The macula is intact. You can see the autofluorescence that's happening. This would be one of those patients that would be a good candidate for a Synfovre or an Izervay, the C3, C5 inhibitors. But they weren't out at that time. You could see what happened over the time here, that it definitely destroyed the fovea and lost the patient's vision. You can see that this immune system is still active around the edges here. This is the active immune system. This is the autoimmune disease part of this geographic atrophy. And that's where these medicines that inhibit C3 and C5 are targeting. So you can see here, Synfovre, and when talking to the medical science liaison, how did that name come about? It is science, fovea, and retina. So science, fovea, and retina. This is Apellis. It was approved in 2023, and it inhibits and targets the C3. It's part of that complement system. Remember, I showed you on Ninja Nerd, there's the classic, there's the lectin, there's the alternative. C3 is pretty high up, and you can see then there's C3A, C3B, C5, and then you have down here at the very bottom, inflammation, phagocytosis, and cell membrane disruption. That's what you want your immune system to do when it gets a virus or a bacteria or an infection. But when you have these genetic SNPs up here in your RPE or Brooks membrane or photoreceptors, and your immune system says, "Hey, let's turn on," then that's what happens, and it starts to destroy the retina. So the idea is these injections go in and inhibit that. But again, now you're monkeying with the immune system, and we're seeing some of the side effects that can come from this. One of them being, like an increased risk of wet macular degeneration that's out there. And then when you start these are injections for life. So that's why I think it's hard, that not every single retinologist has bought into this. Most, there are some retinologists. We just listened to a very skilled one over the weekend. It was was very articulate on how he approaches, the multi lobes, the fovea spared. We're watching this progress rapidly because they are injections for life, at least for life until maybe something new comes out. There's always science, and maybe these medications in the right eye and the right in retinologist will help. So it's basically inhibiting the C3, and that's what Apellis is doing with Synfovre. Izervay by Astellas, it came out as Iveric Bio, then they were acquired, that asset was acquired by Astellas. Both came out in 2023. Synfovre first in February, then August of 23 was Izervay. But this one was going after the C5. But if I go back, you'll see they're both in this article important in the bridging the genetic association and biology down here in the RPE. Again, what we're seeing here with our geographic atrophy. When I get a good candidate, unfortunately, I have to send them towards Harrisburg because my retinologists in the Pittsburgh area are just not doing it, and they come to the Altoona and Johnstown area. And I send them over to them. I don't tell them which one to do. They evaluate the patient. I kind of already grease the skids with the risks and benefits. Obviously, they're heading out after I talk to them, and then they have the discussion, and then they decide but I'm not telling them to use Izervay or to use Apellis. They're going to do a risk assessment and have a discussion with the patient and figure out. But I have a good discussion with them on how these work. So this is where Izervay works down here in the C5 inhibition. These are amptomers. They're a little bit different than the antibodies, the monoclonal antibodies, like Avastin, like Lucentis. Amptomers are still biologics. They're a little bit smaller. They're a little bit more stable. They're easier to synthesize. They're a little bit cheaper to make, and they're smaller in size and have a low or no immunogenicity, meaning getting into our systemic body and wreaking havoc like some of the monoclonal antibodies can do. So, Joe, are there any questions? I know I've been kind of rambling on there for a while. Is there anything that has popped up before we do the next
No,
polling question?
no, there are no questions, so we will do poll question number 2.
So I thought this is interesting and lecturing on biologics and having discussions and, exhibit hall break discussions and coffee break discussions. I consider biologic pharmaceuticals too expensive and this could impact me prescribing them. Yes or no? Biologic agents are too expensive and they could impact me prescribing them. Yes or no?
So the responses are coming in. I think people are pondering it. Like I said, we have a very large audience tonight, so I'll give them a few more minutes to weigh in. It's kind of jumping up, but you've had no questions. We're all caught up on that.
Perfect.
Yeah, it looks like your internet is holding in there, so we seem to be doing well. Fingers crossed.
Yeah, don't jinx it. Don't jinx it.
All right, so I think I'm gonna.
I think my heart rate finally came down and my adrenaline has finally calmed down. So I was like, no.
Well, I'm gonna close the poll and display the results. And 68% say they are too expensive. That would impact them making the recommendation or prescription. And 31% said no, they are not too expensive, probably believing that they have a necessary value and are worth the cost.
Yeah, and that's why, I wanted to have that, and I appreciate it, the honest, reaction out there, and opinion in the opinion that you gave for that. So let me kind of walk through some of this, and maybe that will help unravel and maybe have some people feel better about the cost of these medications. The first thing we need to realize, like say for Oxervate or for teprotumumab, or any of the biologics that are out there. Those are the ones that are used for the eye. But the Avastin, Lucentis, those are biologics. Some are more complicated and involved in making, and that's what I want to walk through here. It's totally different than what I would call small molecule drugs versus biologic. So aspirin, penicillin, Lumigan, kind of mixing of compounds and reagents together, organic or inorganic chemistry. Biologics are truly biologics. It's genetic engineering that's out there. And small and the size and complexity of biologics. Small molecule drugs tend to be taken orally, right? So you can take aspirin orally. There are very few biologics that are able to be taken orally because they're so large in size, which I'll show you here shortly. So I'm showing here aspirin molecule, around 20 to 100 atoms. Small biologic like hormones are up to 3,000 atoms. And then you get some large biologics such as your antibodies. And that's why I always like to point out, if you look at the name of a biologic, it will have towards the end, if it's monkeying with the immune system and it's a monoclonal antibody, it will say MAB, monoclonal antibody, like teprotumumab that we were showing earlier. Now, this could be up to 50,000 atoms in size. So with that being said, let's just look at this picture. Here's an aspirin. Here's a hormone like insulin. Over here is IgG. This is what's used a lot in myasthenia gravis. I have a couple patients that go and get their IgG infusions that have myasthenia gravis. Just look at this aspirin size, look at this, and then look at all the hydrogen bonds, look at all the twisting and turning. The other thing about biologics I like to point out is they're very delicate. And I know, like the COVID vaccine being really recent in people's minds, it had to be shipped frozen because when it's frozen, it gives it more stability. And a lot of these biologics are like that because you really don't want to like put them into like a way you're going to infuse them and let's give them a good shake here because you're just going to bust this all up, and create problems. So my point is what I'm trying to say is these are totally different, pharmaceuticals when they're out there. The complexity, the aspirin would be, not the bikes are, they're nice, simple machines in a sense with a chain and pedaling and so on and so forth. And some can be very complex, but still the most complex bike is not going to get up to a jet airplane here with cost and size and complexity of all the radar systems and weather systems and all the different ways that it can be uh, different than a bicycle. So real simple here to kind of boil it down. If you wanted to make an insulin growth factor 1 antagonist, as in teprotumumab, or let's take it a different way. Let's get outside of something that is a monoclonal antibody. How about endogenous growth factor? That's exactly what, oxyrvate is. It's a growth factor. So it's not monkeying with the immune system. I don't think we're going to be talking about oxyrvate tonight in this. I have a whole other neurotrophic keratitis talk that we talk about, but I love it because it has nothing to do with monkeying with the immune system. We know that in neurotrophic keratitis that endogenous growth factor is missing. The trigeminal nerve and the epithelial cells have to play together very nicely, and that growth factor is missing. And when we add it, a growth factor, nothing monkeying with the immune system, it can heal neurotrophic keratitis. Now, what did they do? How do they make endogenous nerve growth factor? Well, how do they make an insulin growth factor 1 antagonist? They figure out the DNA structure, and it gets plugged into a yeast, a bacteria, or some type of cell. And then it goes through the RNA and DNA, all kinds of synthesis. And then it spins out a protein. And then typically there's a proprietary process of spinning that protein back into the original product. So it's a DNA. It's really truly genetic. In teprotumumab, they use a Chinese hamster ovary. They found out the DNA sequence, they run it through a Chinese hamster ovary, it spits out the protein, and they have to twist it up. In oxyrvate, they figured out the DNA of the DNA structure of true human nerve growth factor. They run it through E. coli. It goes through a proprietary, or it goes through the protein and RNA and DNA synthesis. It spits out the protein, and then there's a proprietary way that they're able to make it look exactly like endogenous human nerve growth factor. That's why it goes into a glass bottle. It has to be shipped a certain way, and that biologic is then drawn up out of that into a pipette and then dropped onto the eye. That's a little bit different than making a bottle of proparacaine. That's a little bit different than making a bottle of Lumigan. With that comes a cost. One of the first biologics that came out for the treatment of choroidal neovascular membrane, retinopathy of prematurity, diabetic retinopathy, they were the vasoendothelial growth factors. The one back in 2004 was an RNA aptamer. It was Macugen. It worked pretty good, and then it got set aside by Avastin. And as you look, you can see it's a monoclonal antibody, humanized, full-length monoclonal. Then Lucentis came out in 2006, Eylea 2011, and then Beovu came out in 2019. And that was supposed to be a really big hit. And I was geeking out with the medical science liaisons, learning about it. And the big hit was it was going to last up to 3 months. Now, what happened to it? That's why I always like talking about the immune system. Beovu, when it was injected into thousands of eyes, right? It went through the phase 1, phase 2, phase 3 studies. The phase 3 studies usually has a dosing that's usually 1 and 2. And then they usually have a safety study that goes 180 days. It could go, 6 months to a year. And they're trying to find all the side effects. Well, when you're injecting it in 500 people's eyes, and then you get it out onto the market, that's when you start seeing all the side effects. Just kind of like we see the side effects of the fluoroquinolones, right? If you stay up late at night, just like I am, building up lectures and doing outlines, and you have TV running in the background, hey, have you taken Levaquin and have you had a tendon rupture? Well, why didn't that come out in the phase 3? It just wasn't enough. And that's what happened whenever we saw the COVID vaccine, right? The COVID vaccine was injected, I don't know, hundreds of millions of people, I don't know, billions of people, and you're monkeying with the immune system. And that's why all at once you saw all the side effects. So if we would do that with Beovu and inject it in people's eyes, if we would take that with Levaquin and give it to billions of people, we would quickly find out all the different side effects that's out there. Again, not defending the COVID vaccine, But to me, it was no surprise because it was a vaccine that was monkeying with the immune system. Supposedly, it was the RNA DNA sequence of just the crown. So they found out the DNA sequence of the COVID vaccine, figured out what the crown was, made multiple of that, injected those into the body, and let the immune system react to the crown and not the virus, so that if they came in contact, they'd have a reaction. But it was all that DNA, RNA type of synthesis. Now, Bayview, when they started injecting it, it started creating intraocular inflammations, vasculitis, retinal artery occlusions. You could see here what was happening. So again, monkey with the immune system, Bayview, if you look right up there, MAB, monoclonal antibody. And so what they found out was, and what they were hoping was, they were hoping that it was a purification process. When you make these biologics, sometimes they're just not pure. And so you can clear, and the patients are reacting to a contaminant. Maybe they can change something in it. Unfortunately, that wasn't it. Talking to the medical science liaison, what I found out was certain patients had an antibody for the antibody. So whenever they put this antibody in, the immune system said, no more. And it attacked it and created inflammations, vasculitis, artery occlusions, and so on and so forth. So they said, all right, well, retinologist, if you want to use this, just check the patient for this antibody. We now know how busy retinologists are. Were they going to check it? Be another visit? It would delay care. And then on top of that, once they injected them, could their immune system not create an antibody for the antibody? So it kind of phased out. Goes back to the madness of why I talk about the immune system receptors, the importance of knowing it. Now, what has changed with our biologics is
Actually,
Eylea.
hold on for a second, Greg.
Okay.
You touched upon this. There are two questions that came in from one person, and you were really kind of answering the first one. How does the COVID vaccine fit into this? And part two, there have been many reports of the vaccine linked to blood clots. Are we worried about BRVO? And I guess I would go on and say CRVO
Yes.
or even CRAO.
Yeah, so I think it's all of that is all in play. So I kind of talked, I guess, like you said, Joe, about the first one is, the vaccine. It could be anything. It could be this like this here, Bayview creating an artery occlusion. You're going to have an immune reaction. And it goes back to, who was having most of these reactions are the people that are metabolically challenged in a sense. So, insulin resistant patients, insulin resistant not only creates type 2 diabetes, it's not the insulin resistance, it's the hyperinsulinemia. The hyperinsulinemia creates the insulin resistance, which then creates the type 2 diabetes, but it creates obesity. It creates hypertension issues. It creates a dyslipidemia. That's why your triglycerides and HDLs. They're now talking about type 3 diabetes. I hate that name because diabetes gets linked to glucose. Type 3 diabetes is Alzheimer's and dementia. If you go through all of those, Alzheimer's, dementia, obesity, dyslipidemia, hypertension, type 2 diabetes, it's all linked back strongly to hyperinsulinemia. We should be getting our fasting insulins checked, not our glucose and hemoglobin A1Cs. But those were the sick people. And whenever you have metabolic disease, the first thing that goes is fat. The next thing that goes is muscle. Then the next thing to go, pay attention, everyone, the immune system. And so when you have the immune system and muscle and fat not working together and your hormones are all off, and you start injecting certain, not saying the COVID vaccine, any of these, you can have complications because the immune system is not working properly. We're metabolically fragile. You have blood clots, you have heart attacks, strokes, you can have lots of things happening. So, everyone, lift weights, exercise, get good sleep,
Yep.
and have good nutrition.
You broke up for about 5 seconds, Greg.
I just would say, everyone out there, get good sleep, get exercise, and have good nutrition. Are we good?
We're good.
Okay. Any other questions?
Nope, you got him.
All right. So go back to we're talking about the biologics. Eylea, what you see from time to time is they keep adding indications. I think we all know if these probably make sense in these retinal vascular diseases that it would work for diabetic macular edema and diabetic macular edema for vein occlusion and diabetic retinopathy and wet and diabetic retinopathy and retinopathy of prematurity. But the reason they get these indications is to help with insurance coverage that's out there. So that's what you see the changes with Eylea. Every so often, you'd be like, oh, we got another indication that helps with coverage. The other thing that happened is that they have a high potency Eylea now. It's 8 mg. And from when I last checked, the 8 mg had two indications, diabetic macular edema and wet AMD. And your Eylea had five indications, as you can see, retinopathy, prematurity, diabetic retinopathy, edema following a vein occlusion, diabetic macular edema, and wet. So really not much change with these in the vascular conditions other than the fact that there's a stronger dosage and they just try to get they try and get more indications to help with the insurance side of things. One I've seen happen is that there is a generic, if you want to say, it's called a biosimilar. You can't really have a generic, so they're called biosimilars of aflibercept or Eylea. And this one's by Amgen. And I just saw in the last few weeks a few of my patients coming in from the retinologist that they are using Pav Blue, which is aflibercept, which is the biosimilar, and it has the indications for macular degeneration, vein occlusion, diabetic macular edema, and diabetic retinopathy. They usually get the similar ones because, again, they have the DNA structure of this. They run it through some RNA, DNA, and that's why it's always going to have the same name, aflibercept, but that's why they tag on these four letters. If you go back to the reference model, you'll see that this one does not have, and you heard me say I'm doing work in some registries that are out there. When you plug them into registries, and registries are going to take away the bias that humans can have, if you type in aflibercept and you type in aflibercept and you type in aflibercept, it's not going to know which company is the best. So, or if there's any difference that's out there. So now when they name these, they add on these four letters to the biosimilar. And even now when a new one comes out, they'll put the four letters on it. It looks like they leaned on the keyboard and picked the first four. I think that's how they do it because the reference molecule, the AFLIB, the afliber sept, they all has something to do with the name. When you look at a monoclonal antibody, like the ZU means like humanized, and the bro and everything will have a certain naming. There's a whole nomenclature to it, and you'll see here that this one doesn't have the four letters. The four letters are now being tagged on to the reference and the biosimilar to be able to tell which company it is. So AYYH, this tells you that it's Amgen's. Staying within the biologics, Genentech, they've come out in February of 2022 with a dual mechanism here. Monoclonal antibody, again, you can see here the MAB. And on this monoclonal antibody, it has its traditional anti-VEGF, but on the other side, it has an anti-angiopoietin 2, which, as you can see here in the picture, it says may reduce or it reduces inflammation and vascular leakage. And then over here, it inhibits the vascular leakage and the avascularization. So it's got a dual mechanism kind of acting synergistically. And that's why I think if you follow your patients, they'll try the Aleas, the Pav Blues, the different types of biologics in vein occlusions and macular degeneration. And if they're not getting the reaction or the outcome that they're looking for, then you'll see them use Vabysmo, which is a dual mechanism going after that angiopoietin 2 inhibitor and the VEGF. It's kind of working synergistically again, reducing the inflammation and vascular leakage along with inhibiting the vascular leakage and the neovascularization. All right. So I'm going to take a little break here and have you
Hmm.
run this poll number 3. I'm
I
going to
will
reach
do
back here
that.
and grab a water.
Okay. Poll number 3.
All right. Have I prescribed XDEMVY for Demodex blepharitis? Yes or no? And then when I use, if you are one that has used it, have you used it with success?
And a question had come in, Greg, any clinical trials or studies going on regarding using diabetic medications for Alzheimer's or dementia?
So the answer to that is yes. That there's lots of trials out there with helping with the insulin resistance, insulin hyperinsulinemia, and helping with preventing, again, type 2 diabetes, hypertension, dyslipidemia, obesity, and Alzheimer's. That's not going to be a phase, that's not going to be your double blinded studies. It's hard to do long-term studies on these conditions. What happens is it's evidence informed, risk adjusted medicine. And then, so that's the first phase is saying yes. And then, are there then pharmaceuticals that can be looked into? The GLP-1s are looking into that to see if it can help with the dementias. I'm building a lecture right now, so that would be your semaglutide or your Ozempic, Monjaro, which is your tirzepatide. And Joe heard me say numerous times over the weekend because we were in Nashville that I just think that those are just given a too high a dose in someone that's brittle. I think you're going to see they're going to start off at lower doses. We already see that in some of the compounding and titrating them up. And I think you're going to see that it's going to help repair that vagus nerve. It's going to help people with all those, along with the Alzheimer's and dementias.
Well, I'm going to close the poll. Oh, display. And it looks like we're pretty split. I prescribed Xdemvy for Demodex blepharitis. 47% said yes, and 53% said no. Now, when I used Xdemvy, it was successful. 61 said yes, and 39% said no, which actually kind of surprises me a little bit.
Yeah, that's why I wanted to throw that in there just to see what the audience was. Again, I'm surprised.
Mhm.
I thought that the number would be more 90-10 or 80-20 rather than a 60-40. So again, this is why it's in here. Maybe we can learn a pearl or two on how to use it. So
And
I
and
go ahead, Joe.
before you get rolling on it, are you using ivermectin for the Medicare patients who are successful at Xdemvy but have recurrence?
I have not used ivermectin for this. I understand. I get it, and uh, the the um, the the pharmacology behind it, but I really haven't had any issues with the Medicare patients with XDEMVY recently. I think we just have to ask. I just tell the coach the patients to see if they have any assistance programs, and that usually can resolve the issue
Yes,
that's out there.
agreed. I agree. All right.
Okay. So, Demodex infestation, collarettes are the pathognomonic sign. I think the biggest thing is you have to make sure that the patient is looking down to be able to get the waste products and the eggs. If you're looking straight ahead, you might not be able to see those lashes as they look down. The hallmark sign, as we learned at PCO years ago when Joe and I went there, that was the way the hallmark sign of Demodex blepharitis would be the collarettes and having the patient look down. And so what you can see here, the collarettes at the base of the lashes. And I always like to tell the funny story of I used to call this Demodex poop, and no wonder if there was poop building up at the lashes, you would see how the uh, the blood vessels were kind of creating inflammation or making a pipeline down to bring in the white blood cells to maybe clean this up. And that's why the patients would have red and inflamed lid margins or itchy lid margins. The meibomian gland oils would get disrupted because there was this whole parasite upset going on. Now, going back, you heard me go off on a tangent of hyperinsulinemia. I think one of the side effects of it is dry eye and this disruption of the, we talk about the gut microbiome, but I think the lid microbiome gets disrupted from our normal bugs, the Staph aureus, Staph epidermidis. And remember, Demodex are found on all of us. It's just that there's an overgrowth here. So XDEMVY or lotilaner ophthalmic solution 0.25% is by Tarsus for the indication of Demodex blepharitis. Its mechanism of action, you heard me talk about that earlier today, is the mechanism of action is that it inhibits the parasite-specific GABA chloride channel. What that means is humans do not have it, and that then increases the safety profile of this medication. This medication is used 1 drop twice a day for 6 weeks. If I do this in a live audience and I say, have you seen success in 3 weeks? They'll raise their hands and say, yes, the lashes look great, but you want to do it for 6 weeks. I just tell the patient twice a day until the bottle is empty. They'll go beyond 6 weeks with that. And a sales rep cannot agree to that. They'd say, sorry, we have to tell you to use it for 6 weeks. The medical science liaisons would be like, okay, nothing wrong with that. Sounds okay. No side effects are happening. Again, at that 3 weeks, you want to go to 6 weeks because you want to make sure you get the eggs. There's eggs there. When they hatch, you want to make sure you get the new parasites from that to get a higher success rate. So 1 drop twice a day for 6 weeks would be your on label, and 1 drop twice a day for at least 6 weeks or until the bottle is empty would be the other alternative, which would be the off label. I also tell the patient, because the drop is bigger than the 10 microliters, some will probably run out. So that's okay. Please just take your finger and just run it into the lashes. So that will just help, to me, with the efficacy of getting the drug about where those mites are living. So here's a 45-year-old, what I say, somewhat symptomatic. When he came in, you could see I pointed out how his eyelids, the blood vessels are very inflamed. They shouldn't be that big, and heading down towards where I used to say the poop is building up. And then I was in doing a live class, and one of our colleagues raised their hand and said, hey, doc, whenever I was an undergraduate, I studied the Demodex mite. It was part of my whatever PhD dissertation, part of their research, whatever they were doing, helping a professor. And he said that these mites do not have an anus. And I was like, darn, you just blew my story. It was Demodex poop. It was building up an irritation. So we went back and forth and we had this discussion, and we found out that it's more like vomit that's coming out. So whichever way you want to look at it, poop, vomit, it's building up on the eyelashes and it creates an inflammatory reaction. You could see you want to have the patient looking down. This was a somewhat symptomatic because he was 45. And I said to him, I said, look, this is what's happening. We can wait for it to get worse, or we can treat it now. He's like, doc, I don't want poop or vomit on my lashes. Fix it. I kind of feel, like it needs to be fixed. And I think I have some symptoms now as you're talking about it. Once I fixed them, he knew then how bad his eyelashes were feeling. So here's the original up here, 5 weeks. You can see down here that he cleaned up really nice just with the 1 drop twice a day. This is 5 weeks. I would have just told him to use it for the 6th week until it's empty. What I also like to point out is sometimes you'll still seem like there's a collarette right here. What I would encourage you to do is just take a cotton tip applicator or a Wexel sponge, like a sphere, and just hit that. What I've seen at times is it kind of becomes like fossilized or crystallized. And when you hit it, it just kind of poof and goes away. Sometimes, even showering or washing doesn't get rid of it, but you hit it with a cotton tip. So this is probably not a remaining collarette or an active infection, but more of kind of a fossilization of it. But you can see how nice he cleaned up. in just 5 weeks of using this medication. So, here's a patient again. Here he is. This is time zero, 3 weeks later, and 8 weeks. So maybe that is, looks like the same picture there. Maybe that is 5 weeks because it's right there. So there's 3 weeks. And then here's at the end how nice he cleared up after using it for 6 weeks until the bottle was empty. So this was a neurology friend of mine. He came in. We kind of geeked out about the you can see here in the live, if you kind of move around a little bit more, you can kind of see as they look down, you can see the collarettes building up on the lashes. Um, we geeked out a little bit about the GABA chloride channel. He was a neurologist, and he's like, oh, that's kind of cool, and he kind of learned the pathophysiology of it. And so here he is here 3 weeks post-treatment. He was a little bit freaked out that he had these little bugs growing on there, so he wanted to come in. And you can see that at 3 weeks, he starts to clear up pretty nicely on his lids. So that's my bow. I usually have some other cases in there, but since it's been out for such a while, I would encourage you to me, it's a great medication for optometry. It's great for ocular surface disease. There's some great phase 4 studies that are coming out. I'm going to work with the medical science liaison to get those and add them into here, where it's actually been shown that it's helping with meibomian gland dysfunction. So those that are out there doing IPLs and doing all these lid treatments and all this ocular surface, I find this to pair very well. I do IPL in my practice, intense pulse light. We do it for dry eye. We do it for some rosacea. You can use it also for, you can use IPL for Demodex. I think if you use it for Demodex and would use XDembi, I think you would find a great synergistic effect that's out there. So I would encourage those that are out there who haven't used it to talk to your rep, get all the findings, because for those that are cutting teeth and maybe want to use a pharmaceutical and get into some medical optometry, to me that's a really easy one. It doesn't have a lot of side effects because if it's inhibiting the GABA chloride channel just of the mite. It's a short week. It's not like, hey, one drop twice a day for the rest of your life or for the next year. It's a short-lived. You get some good efficacy out there. I would encourage those. So, Joe, any questions on that before I move on, or any comments? Because I know you've used it.
I use it quite a bit. I do several probably several a week. Let's see what we have in here. So many comments. I find exdemry recurrences not uncommon. What do you find?
Yeah, so that's a great question because that question just came up in Nashville. And so I'm pretty well versed on my answer now that I was able to think about it. And the answer is, now that I've used it for 2 to 3 years, I do have a low reoccurrence rate, but I do have them poking through from time to time, where I've used another dose recently, a second round, 2 years, 2.5 years later. But it's kind of funny if you go back, and it's not funny, I guess, kind of ironic in a sense. It's not the most metabolically healthy person that's there. So I think it's their immune system having trouble. Maybe their lid microbiome is disrupted. And that they're having a tough time with their immune system. Remember, fat muscle immune system goes in a metabolically challenged patient, so maybe their immune system is being struggling there. Maybe I should be telling them about hyperinsulinemia, treadmills, sleep, and nutrition. But we did a second round, so very rare. But I'm starting to get a few of them poked through.
Do you use low-level laser red light therapy to treat Demodex?
I have not. I've used intense pulse light. I haven't gotten into the photobiomodulation, the low intensity lights. It's the next thing I'm going to conquer in my anti-aging realm. The yellow light, blue light, red light. Using light they're using light now to treat macular, drusen, photobiomodulation. It's a huge field. It's a complex field, getting the depth of the tissue, the right wavelength of the red or the blue or the yellow light. I've studied it enough to know and be dangerous about it. But a long-winded question that no, I have not used it
Mhm.
yet in my office.
And just a few comments. Somebody said they used it once successfully, and another comment they had lid scrubs as adjunctive therapy.
Yeah, that's a great,
Mhm.
that's a great follow-up. Sometimes I'll use Claridex, right? Claridex is tea tree oil, a natural way of treating it. I don't like them to use the ones over the internet or Amazon. You don't know the ratio. Claridex is, is an eye company by, I believe it's BioTissue that does it. It's Claridex is the product. And they have a foam and they have a little bit of a, like a, looks like a wet nap. Tea tree oil works great. That's made for the eye. So a lot of times afterwards, if they've had a severe infestation and they're like, "Hey, what can I do to prevent this from coming back?" I'll use a Claridex, which is a tea tree oil, or you could do a lid scrub. That is a great comment. Thank you for saying that.
All good? Oh,
Okay.
hold on maybe one more question here. I've heard in a lecture that Demodex mites can live inside meibomian glands, and you may not necessarily see collarettes. Have you prescribed based on symptoms alone?
Uh, yeah, I'd like to see that. If they can live in there, I'm sure they could. I know that there's this huge association that's out there now that whenever you have meibomian gland dysfunction and you use XDEMVY, that it can improve. And maybe perhaps it's because the Demodex is living down there. But
Mhm.
let's make the I guess what we do know, clarification is that we do now know that XDEMVY can help with meibomian gland dysfunction.
Yeah, I think that's pretty clear. I'll give you my another question, and this is from me. Do you treat all Demodex, Greg? Or do you ever see that, those patients throughout the day, you look at it, you see a few, you know it's low level, they're not symptomatic. Do you ever just let it go?
Oh boy, it's probably rare that, well, let me do this, Joe. The answer is yes, but let me kind of explain how I do it is that I have an anterior segment camera in each of the rooms that I work in. So when I do see it, I take a picture of it, explain it to the patient. And so I tell them what's going on, and sometimes they're just like, no, I don't want a pharmaceutical. No, I'm asymptomatic. So I say, okay, I have a picture of it. We can take it next year and we can reevaluate. So I think the answer to your question would be I bring it up to just about every patient because I can take a quick photo of it. But do I prescribe it on everyone? No. But whenever I tell them it's poop and vomit, they usually don't want to get live it on there. But there are patients that don't want to have it fixed.
Mhm. Very very good. Ready
Good.
to rock.
Okay.
I was going to ask what anterior segment cam do you use?
I have the Firefly that's out there in both rooms. I forget what company makes it. I think it was recently bought out. It was Mark Newkirk that had it at one point. He was my rep that I was using, and then I think they got bought out. But it's called the Firefly. And again, not saying that it's the best and not claiming superiority out there. It's just the one that I use.
Very good. Ready to
Okay.
go.
All right. So, dry eye has been becoming exciting here. Yeah, we have Mibo by Bausch and Lomb and that's made by Bausch and Lomb, approved in May of 2023. I really like this molecule. It targets the evaporative side. It's perfluorohexyloctane. What I love about it, it's 100%. So it's not a steroid. It's the 100% means that there's no water, no inactive ingredients, no preservative. No water means that it can't get an infection in it. It means it doesn't have a pH in it. Again, and that's what leads to no preservative. It's 100% molecule that's in the bottle. It's one drop 4 times a day into each eye, and it is an eye drop. And again, here's the unique characteristics: single agent, no inactive ingredients, water-free, preservative-free, and it mimics the function of the natural amibum. But here is one of the first examples now of that 11 microliter type of drop. Here's the issue with this drop is that the patients really can't feel it going in. It's so small, it doesn't burn, it doesn't sting. So there's actually this way that the sales reps are kind of teaching, like, take the cap off, squeeze the bottle, turn it upside down, release it, and then have them put a drop in, because we've had patients not feeling it and kind of blowing through the whole bottle in like 2 days because they don't feel it coming in and it's not running down the face, right? So they don't think it's going in there like the traditional eye drop that's out there. So sometimes we fix the things and then we create issues. So we have to kind of learn how to teach these patients about this drop, because it doesn't sting, doesn't burn. It might cause some blurred vision, and it's so small that's out there. Again, most dry eye is, they say 86% taking the mixed and the 50%, which is true evaporative. So just think about when you give someone tears, you're just kind of treating that 14%, or if you add the 14 and 36, but you're not really getting to the evaporative side. And what happens with when you have evaporation, I'm going to use this slide because you see it, but I'm going to use the next slide to kind of walk you through it. Desiccated stress, tissue damage, and inflammation, and it kind of circles, but it all starts with evaporation. But this is my favorite slide. I do speak on B&L from time to time. I just did one a few days ago. It was a dinner program, and I love going through this slide because I love showing this is the way the tear film should look. This is properly hydrated down here with the cytokines, chemokines, electrolytes. And if you have evaporative disease, now what happens is the picture to the left. And when you have the lipid and it evaporates, then what happens is the aqueous and the hydration part becomes, I always say, too salty. It becomes dense. These are your patients that are have their when you test them on the devices that test for hyperosmolarity. This is when they read high, right? This over here is a nice ratio of the cytokines and chemokines properly balanced. Over here, your balance is off. It's it's a hypertonic solution. There's not enough water in it. So if there's not enough water in it and the body loves to be in homeostasis, where's it going to pull the water from to get this to balance? Now, maybe if you lived in Florida like Joe does, maybe there'd be enough humidity in the air to help out. I doubt it. Even in Sarasota, Florida, there's probably not enough humidity in the air. So now it's going to pull the water from the conjunctiva and cornea epithelial cells. And if you look down here, what they're trying to show in this cartoon, because this is a hypertonic solution, the body loves homeostasis, right? It always likes to be in balance. Again, we have a parasympathetic system and a sympathetic system. If we're dehydrated or if we have too much sugar in our body loves homeostasis. It's going to do something. It's going to try and fix itself. Unfortunately, the cornea and conjunctival cells are the ones, the epithelium, that then become stressed. That's your desiccated stress. That's what that is. Tissue damage. What happens is then when the tissue becomes too dehydrated, the cells will die. The cornea cells will die. They have phospholipid bilayer membranes. That goes into the arachidonic cycle. Now you have prostaglandins and leukotrienes, and then you start getting inflammation and inflamed nerves. So that's what is happening with desiccated stress, tissue damage, inflammation. It all starts spinning if you lose that lipid layer and you get evaporation. So this is just a bad cycle. So the idea is if you can use a molecule that can help seal off the lipid layer, that's what Mibo does. And this is a 14 carbon with 6 of them that are fluorinated and 8 of them that are not. They are aerophilic and they have hydrogen on them. So they're like bobbers that you throw. Like if I was just thinking of taking like 1,000 bobbers and having a bunch of people with them in trash cans and just dump them into the pool. They'd all kind of flip and then they'd all go, red top, white down, and then it would kind of seal off the swimming pool. That's what this molecule does. It creates a little mono layer and it helps seal off that lipid layer. And with it, you have excellent tolerability because there's no pH. There's no BAK, there's no preservative. There were 0 adverse events, low discontinuation, low burning, again, no pH, And there was only one ocular side effect, a blurred vision. You put an eye drop in, that was greater than 2.1% that's out there. So that's MIBO. It's, it's a comfortable way of treating dry eye, which is targeting. All right, so let's do this polling question, Joe, and then if
All
there's any
right.
questions, I'll answer them.
Let me look at the questions first. Okay, we're good on that. So I will go to poll number 4.
And regarding Vivi, and Sequa, both cyclosporin products are good examples of a change in mechanism of action or mechanism of delivery. Vivi and Sequa, they're both cyclosporin. These are good examples of a change of what?
All right, the responses are rolling in. You're caught up on the questions. And everything is sounding good so far, Greg.
I had a couple lightning flashes here recently, so I was kind of a little scared, but
Mm-hmm. We'll give it another few seconds. Make sure I don't shut it down too quickly. All right. And just make sure it's the icon on the right that says polls. That's where you go to get it. I'm gonna close the poll and display, and 70-30, 70% mechanism of delivery versus 30 mechanism of action.
all right, fantastic. Mechanism delivery this is what I'm going with as a great example. Let's just kind of go through and I'll explain. Is really Restasis is cyclosporin, Sequa is cyclosporin, Vivi is cyclosporin. They're all the same in a sense, cyclosporins. They've changed the mechanism of delivery. Remember back in the day, I can't believe I just blew this one out of the cobwebs, is that Restasis was Indura. When they were having trouble bringing it to market, they brought Indura out, and that's the mechanism of delivery for Restasis. So the Indura and the cyclosporin. And then Sequa is again cyclosporin. It inhibits that calcineurin inhibitor inside the cell. That's a big one that's out there. It inhibits inside the cell and it helps decrease those cytokines. Now, what has changed is that Vivi here is double the percentage. So here's the issue. Let me step back before I do that. Here's the issue. I love cyclosporin as a immunomodulator, calcineurin inhibitor, immunosuppressant. The problem is it's a fat-loving molecule, and you're dropping it into a water mucin-protected type of eye. So it's hard to get this molecule to the tissue. We know that by science it's going to work, but the eye has one heck of a robust defense mechanism. That's why we get more upper respiratory, sore throats, runny nose, rather than pink eyes. It's the same viruses, but we have a really good immune system in the eye. But when it's overcome, it can get really sick. But again, now what has Harrow done with Vivi is that they've doubled the percentage. It's 0.1. It's not 0.05. It's double the percentage. I like it because they're trying to get the medication there. They're using the perfluorobutane, butylpentane as the mechanism of delivery. It helps deliver the medication to those tissues. Now, what's really cool about this bottle and this molecule, how Harrow's come up with it, look at it. There's no pH. It's water-free. It's preservative-free. It also has a low surface tension. I've never was a big cyclosporin user until this medication came out, and also with Sequa when it came out because it had almost double the percentage. And I've had some really great outcomes recently with this because of the mechanism of delivery, the increased percentage. It's twice a day, just like the Restasis. It comes in a multi-dose bottle, but it's not preservative. It doesn't, because it's 100, in a sense, almost 100% free of the medication, and it's 10 microliters. Again, look, there's that drop size being, and we're seeing results significantly sooner than we have with Restasis in the past. And again, just a reminder, that's why there's the nano dropper out there addressing that drop size. And that's why you see that, because again, the eye can only hold 10 microliters, and the drops are usually 30 to 60. Sequa is now another mechanism of delivery. So the 70% of the audience that went mechanism of delivery with Vivi, again, the perfluorobutyl pentane is delivering this cyclosporin. When it comes to Sequa, they're using a nanomicellar ophthalmic solution. Remember, it's a fat-loving molecule. This is what Sun did with this molecule. And again, it's the same, for the signs and symptoms of dry eye. And here's really what I want to get to. If you look at this micellar, so the drug is lipophilic. They came up with these polymers, which are hydrophilic on one end and hydrophobic on another end. So the fat-loving go to the lipophilic side. Then you have a water-loving side. So it's kind of like a capsule. Whenever you drop it in, it kind of mixes with the tears, and then it releases the drug. So a mechanism of delivery change of getting that cyclosporin to the tissues. They've done plenty of phase 4 studies out there. So if you love evidence-based medicine, you can reach out to the medical science liaisons, and you can see that they even did a head-to-head study against 0.05, almost doubling to 0.9, getting that increase in cornea fluorescein score, in that Sandy score that's out there, conjunctival staining, Schirmer test. So we know that this medication will work. We know cyclosporin will work. It's just you have to get it to the tissues, to the cornea, conjunctival, lacrimal gland, and it will create that immunomodulatory, and that's why you're seeing this mechanism of delivery changes. All right, let's talk about Tyrvaya real quick, and then we'll talk about some of the presbyotic, or talk about Triptyr. I definitely want to make sure I have time to talk about Ella here towards the end. So I'm going to go through these pretty quickly. This here is Tyrvaya. This is a nasal spray. And what the target is here was to squirt it to the nose, stimulate the trigeminal nerve, and get all the tears producing, because there's proteins, there's electrolytes, there's mucins, immunoglobulins. We talked about IgG, IgM, IgA. We have nerve growth factor, lysozymes, lactoferrin. There's over 1,500 proteins and all kinds, like there's 3,000 components being found in this tears. And what's happening over here, this is normal. Over here, we're starting to get that evaporative, and this is hyperosmolaric, and it's going to steal it from those conjunctival and cornea cells. So what we're saying is there's no substitute to the natural tear. If we can stimulate that parasympathetic nervous system, and that's what they're doing here with Tyrvaya, and it's the afferent going back and creating an efferent type of reaction to that lacrimal functional unit, which is the lacrimal gland, meibomian glands, goblet cells, trying to create that natural tear. And that's what Tyrvaya is doing. Triptyr is the new one that's out by Alcon. It's the first-in-class neuromodulator eye drop. And when you put it in the eye twice a day, about 12 hours apart, it's working on the transient receptor potential melistin 8 receptor. This is a very special receptor found on the cornea. And this is not treating inflammation. This is not a steroid. There are thermoreceptors found on the cornea which can detect temperature change. That was the big finding with this tripped M8. I think it might have even been like a Nobel Prize type of finding, is that this receptor is that if I cover my eye can heat up to 95 degrees. If I keep it open and not blinking, it cools down to 82 degrees. The idea is temperature change as it cools, it gives an afferent feedback to the brain, and it says, hey, you're cooling, send more tears down, because of when things evaporate. So by stimulating this TRPM8 receptor, it creates tears, and a more natural tear. I'm going to tell you, I've used it on about 8 patients with some really good success, but I will tell you, It's a neuromodulator. Warn them, it will burn, but it's a different type of burn than a pH burn. This is different than a pH burn. It's more of a neurostimulator burn. Again, there's the receptor. It's stimulating, it's creating that afferent type of reaction. And then you get an efferent reaction of the basal tears, not reflex. Reflex will dilute all those 3,000 proteins that we talked about that are found in the tears. So what will happen is it creates a good amount of basal tears in the eye. They have studies showing how it helps with the Schirmer testing, corneal staining, and it helps with the Sandy scores, which is basically your symptomology that's out there. So we need to rethink our dry eye treatment when using this. It's not treating like cyclosporin. It's not treating like the lodipredanols. It's not treating like the Zydras. It's not immunomodulatory. So I think this fits high up into the system here, and it could be used concurrently with other medications. But I will tell you, I put it in my eye. It burns. But because when I tested in the patient's eyes, there's always it left over. So I put it in my eye. It burns, but after working on the computers all day when I'm in clinic, it actually makes my eye feel pretty good. I'm 55. I don't think I have a lot of dry eye going on, but it does make my eye feel a little bit better, but it's not going after the inflammatory side. All right. So let's skip this, Joe, for the sake of timing.
Okay.
You know, regarding presbyopia, I'm excited. I'm open-minded, prescribing, not interested out there. Let's just do, you know, the market is big, 128 million people that are out there. You're not going to see this go away. I want to talk about pilocarpine and carbachol versus the non-pilocarpine. Both all of these are miotics. They shrink the pupil. Vuity, Closey, Viz. I just met at Boston with 10 point. They're going to have a carbachol mixed with bromonidine to help with the redness. Those are going to be miotic and going to touch the ciliary body. Viz does not touch the ciliary body, but they're all miotics. So Vuity was the first one. Vuity came out in 2021. It had a BID dosing, then it had a QID dosing. It was basically a re-engineering of the delivery system. Pilocarpine burns because it has to be in an acidic form. So what they came up with this fast pH so that when it was in the bottle, it was a 4, but as soon as it hit the eye, it got neutralized to 6.5 or 7, so it helped with the burn. It was a miotic, but it didn't get the pupil below 2 millimeters, and it did create issues with the ciliary body. It created lens shift, lens swelling, so myopia. And then for those that were out there that talked about the potential retinal detachments. Closely, I don't have any experience with other than I spoke to the medical science liaison, that is Orasis. It was approved in 2023. It's a low dose, but again, it creates meiosis. I don't know how much it's working on the ciliary body. That's what I'm going to be researching next when I talk to the medical science liaison. What we have with Viz is through Lens, it was just recently approved this year in July, is that it is creates meiosis, but it's not creating the ciliary body reaction. It does create redness. It's to me, whenever I was being trained on this medication, as I said at the beginning, I speak for this. I said, look, it's a cholinergic. This is the opposite of phenylephrine. It's got to create redness. But what happened is they reported, about 15% redness, but it was checked at a half hour. And so that's why if you check it, as soon as you put it in, it's really red, but at a half hour it slides. But that's how the study was designed. It can create a headache, but it's not a pilocarpine headache. Here's really the big one that I want to point out is that it works on the iris. It creates meiosis. So does pilocarpine. Here's the big deal. This is the amount of medication that creates 50% muscle constriction. It only takes 900 nanomolars. Just look at the number 900, takes 1800 for Pilo. But here's the difference: ciliary muscle, to get 50% constriction, it only takes 2-to-1 ratio. So it touches the ciliary body. It takes 28 and 22, and they say greater than 20. If you do the numbers, this is 28 times and 22 times. So the amount of 1.44 does not create the ciliary body constriction. So it just works as a miotic. And when they looked at the lens shift, it was minimal. When you look at the lens thickness, it was minimal. When you look at pilocarpine, it's 1.3 diopters. The lens shifts 2.34. You can see there's a bunch of zeros in front of the lens shift and lens thickness. So it is truly a ciliary sparing type of medication creating the meiosis that's out there. It's a cash base molecule, cash base. It's $79 and 170 or 198, which is 66. These are my eyes. This is time 0. This is right after. I said, look, it's going to create redness. It's the opposite of phenylephrine. But here we are a half hour afterwards. Here we are day 1, first day. Oops, sorry, I have the wrong picture in there. Day 1, 30 minutes after installation. This is day 4, day 5. So it does get reversed. Sorry, this picture should be over here. And so this is me at time 0. This is me using it. You could see the amount of the miotic. So this is my patient before, just recently. This is her after. And I forgot to connect the sound, so we'll just skip that real quick. But she was really excited. You're not going to hear the sound because I forgot to connect the sound in the part of trying to get connected. All right, I have 4 minutes here. I want to talk about this one here real quick. Looks like I have to come back and do a part 2. Have I managed the patient on Elahere? You do not have to run the poll. I just want people to ask themselves, have they managed the patient on Elahere? And let me just run through this real quick. This was near and dear to my heart. This is a patient that the two clinical pearls that I want to point out is I want you to, if you have an interest in this, you have to call your OBGYN that treats cancer oncologist, OBGYN oncologist, and tell them, hey, I listened to this lecture. I want to clear these patients. This medication has a black box warning. Ophthalmologists and optometrists have to see them first before they start. This is for a platinum-resistant ovarian cancer that's out there. So you have to call, and then all you have to do, if you can run a slit lamp and fill out a piece of paper, then you can manage these patients. The other clinical pearl is they are sick. We're not used to managing patients like that. And in 3, 6 months, a year, they can pass, even though they might have hope that this medication can help them. And we also have people out there that have seen patients that have extended their life 3 and 4 or 5 years, and they're still living. So basically, it is a monoclonal antibody that is a antibody drug conjugate. Let me just show you here real quick. Here's the monoclonal antibody. Here is the cancer cell, and here's the receptor that the monoclonal antibody is attaching to. And remember, there's a drug conjugate. It's an antibody drug conjugate. The little red is the dynamite. That's the medicine that gets brought into the ovarian cancer cell. It gets released and it kills the cancer cells. You can see here the cancer cells dying. So again, it's biologic. Going way back to the question of maybe I shouldn't prescribe these because of cost. Let me tell you, there's a lot more cancer medications out there that cost a lot more than some of the biologics that we use in eye care. So by us avoiding giving us, not prescribing the patients because we think they're too high, there's a lot of cancer medications out there that cost a heck of a lot more. So I just, say, hey, this is the system we live in. Let me see if I can treat the patient and see if they can get the medications. All right. So your patients will you don't have to do it. So they're not going to come in and they're going to be on Elahere and you're going to be following them because they have to be cleared first. If you're the person clearing them, then there's this whole process of them being on tiers. Here's the black box warning. I think amiodarone is worse than what I've seen with this black box warning. But basically, it creates cornea cysts, cornea epithelial issues, but it's very minor, and that's usually a good sign when that's happening that the medication is absorbing because it goes after cells that are replicating. And if you think about the limbal cells, they're replicating, and so it's bringing the medication in. So that's sometimes why they'll adjust the medication up and down. Now, with that being said, they need an ophthalmic exam. They have some preventative measures, which are lubricating drops and steroids. So they go through different phases. They have to come in. You'll see them at 2 weeks. The oncologist, this is all scripted. They'll schedule it with you. All you need to do is know how to run a microscope. They will start the infusion. They'll already be on tears. They'll already be on steroids. You do symptoms, you do acuity, you do slit lamp. You monitor the patients every other cycle, every 6 weeks for the first 8 cycles of approximately 6 months. Again, it's all scripted. If you want to be a part of this, just call your OBGYN oncologist in the area and say, I want to be a part. I want to help these patients. Here is the side effects. It's all scripted out. Keratitis, uveitis. This is the last one. You could scan this QR code and it will bring you to the form. I have it all covered up here with all the logos for COPE and CE broker reasons. But if you look here, it's basically a baseline acuity, a current acuity. You look at for keratitis, you look for uveitis, yes, no, and you send it back. And now you're a part of this patient's disease management for their cancer. Very rewarding. But they're not going to send them to you unless you call them and tell them that you want to do this. And it's not like, hey, I'm Greg Caldwell. I'll see them 6 weeks later. It's, hey, I will see them that day or the next day they call because it's a last ditch effort. It's a black box warning. I don't want to be the one by saying, hey, I'm so busy. They'll just go elsewhere anyway. But you want to just tell them that you'll see them that day or the next day. All right. So with that said, let me just remind you that probably that little red button has probably popped up.
It
It's
has?
right, it's right there. You could start that survey if you haven't already. And I'm going to say, Joe, are there any other questions in there? And we can make sure we'll get this wrapped up by 10 o'clock, but are there any questions in there? And I want to say thanks for all of those and sorry for about the little bit of a little disruption at the beginning, but looks like the internet held out.
Well, here's two questions. How long do you have people to continue to use MyBo? My patients improve, but can't continue due to cost, 400 to 800 per bottle. And do you
Yeah,
also use Retain, which also enhances the lipid layer?
yeah, I have used Retain. I haven't seen it work as well as the MyBo. I would say maybe reach out to your local reps using the Blink RX. The way they have these paying down of the codes and these discount cards and using BlinkRx and whether it's commercial or Medicare, and every area is different. I would encourage you, that's what the sales reps are for, not the medical science people. Reach out to them and see what they can do because I know with 1 million scripts written that this has got a favorable coverage, and I'm looking forward to see what happens in 2026 now
Mhm.
that the new guidelines will be out.
That's it, Greg. We can wrap it up.
Okay, well, thanks everyone. Truly an honor to deliver this education. We usually have guest speakers, but from time to time, Joe and I take the captain's seat, and it's truly an honor and a pleasure that everyone was here tonight. So thank you for attending. This will conclude the education.